and Chief Medical Strategy Officer at 35 Revive, a longevity clinic built on physician-led integrated care, bringing together modern medicine with functional diagnostics, nutrition, and mind-body approaches to healthy aging. So tonight she'll be talking about a challenging topic, which is something to take, should not be taken for granted. The idea that growing old is the problem. Our session is titled "The Biggest Lie We Have Been Told About Aging," and the argument, in short, isn't that it's not aging itself. We should be worried about. It's about growing unhealthy. So I'm happy to welcome Dr. Uma Senil Kumar. Over to you, madam. The stage is yours.
Good evening, everyone, and thank you very much for your kind introduction, Dr. Arun. And I want to take this opportunity to thank Medverse and BCC for giving me this stage today to share my thoughts on this beautiful topic. They have given me the biggest lie we have been told about aging. So thank you for the stage. And I'll present what I know about aging and what has been a misconception, and then we can go from there. So the biggest lie we've been told about aging is honestly, it's not about aging. Of course, we all know that there's no line about that we don't age, right? We do age. But the lie is the trajectory. The trajectory, we think it is fixed. Once age comes, everything happens, right? The trajectory is fixed. We also think aging is uniform within the body. And we also think it's largely beyond our control. So we think aging has to have a package of diseases with us. It doesn't have to be that way, okay? So aging is not merely the passage of time, but it is the progressive change in the biological resilience. So we're going to talk more about the resilience and the reserve in this next 1 hour. So I focus more on the physiological reserve and the recovery capacity of every individual who walks into our clinic. This is not a talk about, immortality or anti-aging, cosmetic anti-aging, or all the promising age reversal things that are coming up these days. It is about helping people later in their life, like how to live with strength, how to live with a proper cognition, how to live independent, and also have a purpose in life, right? So the real clinical endpoint here is the health span, which is the number of years that you live healthy, not just the lifespan, but the health span. So here I want to say aging is not have to be equal to inevitable decline. Okay, so to challenge this lie, we first need to understand the 3 assumptions hidden within it, and that's what this slide is all about. So aging is, the lie has 3 parts. When I was thinking about this topic, I could summarize this lie could be in under 3 parts. So the first part is we have equated aging with the chronological time. Like when age happens, the diseases happen. So chronological age absolutely is an important risk marker, but it doesn't have to have all the mechanisms associated with the disease process of aging. So second thing is we assume that the decline is uniform. As I said earlier, the decline doesn't have to be uniform. So two people of the same age can have completely different levels of metabolic, cognitive, and physical reserve. So it doesn't have to be uniform. And even within one single person, the organ systems can age differently. It can be like the brain age, the heart age, the lung age, and musculoskeletal age, your bone age. They all can be different when compared to your own chronological age, which is your passport age. And thirdly, we assume that the decline is inevitable and largely unmodifiable. It is not the case, actually. We cannot eliminate aging, but I can assure you that we can significantly influence all the disease risk that comes with aging, and also the functional decline and the physiological reserve. So if aging is not simply the time passing, then how should we define it clinically? So it's a very interesting and very upcoming topic about aging in the field of longevity medicine. So let's explore a little bit more on that. So aging, for me, I define aging as loss of resilience before even the pathology happens, okay? So I think of aging as a gradual loss of the ability to respond or the ability to adapt or to recover from any illness. So the younger our system is more resilient. It can tolerate an infection, it can tolerate a surgery, it can tolerate, even poor sleep, all the stress that we can go through, all the psychological stress, or even it can come back to the baseline much quicker, right? The rebound is much faster. Whereas when the reserve goes down, the same stresses, the same infection, the same surgery can produce a larger disruption in your body systems, and that can lead to incomplete recovery. So the two magic words that I'm going to use throughout this lecture is reserve and recovery. Okay. So the diseases often become very visible only when the reserve crosses the threshold. Okay. We all have to have certain reserve to, it's just like having a bank balance for emergency funds. So when that is there, we don't need to really worry about when the insult happens. The same thing, the bodily reserve has to be there to fight out any insult that come outside of our system. So therefore, waiting for diseases means like entering the process very late, or we are actually addressing the process very late. So diseases often become visible only when the reserve crosses the threshold, right? So when you wait too long, you already have the disease. So longevity medicine, what it does is it asks the earlier questions. What is this person actually causing the erosion of the reserve, right? How steep is the decline of the reserve? That's another question we need to understand. And how can it still be preserved, or how can you rebuild that reserve? So these are all the very valid questions that we need to understand when we talk about aging. So this matters because globally, we are living very longer. As you can see, like the lifespan has increased drastically. People live nowadays to even 80s and 90s, but those additional years are not necessarily very healthier. So that's what we're going to see here. So this is the data I came across. So we are adding years, but not enough healthy years. This is a very important information, that increasing the life expectancy is one of the medicine's greatest achievements, no doubt about it. But lifespan and health span are not actually syncing together. They are not moving in at the same rate. In 2026, the Global Burden of Disease Analysis actually estimated that the global morbidity gap that you see here, the difference between the life years, difference between the years in 1990 and to 2023, the gap was from 8.8 to 10.7 years. That actually widened the health life expectancy gap. So this is the clinical and economic reason longevity medicine belongs inside every mainstream practice. So we should not see longevity medicine as one separate sector, but to see how we can apply that in every sector of the medicine, may it be different specialties. We can apply this particular segment into each and every specialty so that we can improve the quality of the lifespan, or we can add more health span into patients' years. So our goal here is not simply to postpone the death. Our goal must be to delay the multimorbidity and to preserve that function and to keep that capacity to function independently. Also compress that disability into a shorter period instead of extending that the disease span to longer years. We need to compress the disability to shorter periods of shorter period towards the end of life. Okay. So to understand why people lose reserve, we need to look underneath like individual diseases at the shared biology of aging. If you look at aging, there are different mechanisms of aging. Let's dig into a little bit deeper into what really causes the aging parameters and what really causes the diseases. Okay. So I hope you understand so far what is lifespan and what is health span and what is the gap between that and what is really causing that gap. So let's go into that. So here actually is a very interesting and important slide for the entire talk. This explains the hallmarks of aging, where we have a different set of hallmarks. There are 12 of them. They recently added, there were 9, and then in 2023, they added 3 more, and they made it as 12 hallmarks of aging, actually. So if you can see, these are all the causes of aging. So aging is a network. It's not a single pathway that leads to aging, right? Aging and diseases. So it's a big system there. And I'll just quickly give a definition of what this actually means in one line so everybody can relate to what are these technical terms here. So primary hallmarks are basically, if you can see, there are 5 of them here. So you have the genomic instability. What does it mean? It means like your DNA, that is your genes, accumulate the damage from normal metabolism, from the environmental exposures, and it also undergoes imperfect repair. Okay, so all the damaged material is not going out of your system. And then second thing is telomere attrition, meaning like there are protective caps at the end of each chromosome in your body, and that actually shortens. Actually, that is called telomere attrition. When it shortens, it eventually leads to limiting the cell division. Okay. So, and then the next one is the epigenetic alterations. What are those? It's very interesting fact. The instructions that control which genes have to be expressed on or off, it becomes less precise. That instruction that comes from the DNA to activate a good or a bad gene becomes a little confusing, becomes a little precise, and that's what is epigenetic alterations, right? And then the loss of proteostasis is the cells become very less inefficient at producing, the proteins become inefficient in producing, in folding and also removing the unwanted proteins correctly. So that is loss of proteostasis, imbalance of the proteins. And then the disabled macro autophagy is the latest one they added in the hallmarks of aging. It is the cell recycling systems. Like when a cell loses its life, it has to be recycled. When that process becomes less effective, it allows all that unwanted materials to stay in the body, and it becomes more accumulated in the system, and that causes a chain of diseases. So these are the primary damages. When it comes to antagonistic responses, it's very interestingly noted that antagonistic hallmarks are actually protective responses that become harmful. It is like, if there is like a fire happening and there is like a fire alarm that goes on, and once the fire is put down, the alarm has to go off. If the alarm continues to run, it causes a havoc. The same thing here. So when the body is going through an insult, the body tries to protect the insult by giving you all the protective factors. But when the insult or trauma is gone, it has to switch off. When the switch off mechanism is not there, it starts fighting against your own cells, and that's what leads to all of this protective responses becoming more harmful to us. So number one is deregulated nutrient sensing. What does that mean? Is all these pathways, like I don't want to get into a lot of details here, but there is mTOR pathway, there is serotonin pathway. All of these pathways are no longer responding appropriately to the energy that is available. So they don't understand the energy is already there, but they don't respond to the energy that is already available. Second thing is mitochondrial dysfunction. It's a very important piece. So mitochondria produces the energy for your body. Every cell functions with the mitochondrial energy, and that produce less, the energy that is produced is less efficiently utilized, and it also can generate inflammatory signals that are dangerous. And the last one is the cellular senescence here. So damaged cells, whatever cells have damaged, they actually stop dividing to prevent problems such as cancer. But instead of being cleared from the system, they still remain in your blood and they release inflammatory substances. And that substances accumulation can cause senescence or aging that promotes chronic inflammation, or we call it as microinflammation, and it leads to tissue dysfunction. Okay, these are all the antagonistic responses. The important principle here is a response that protects us temporarily may damage us when it becomes a permanent sequence. And lastly, the integrative hallmarks. This is like a whole tissue and organs are affected in this pathway. So these represent the downstream consequences of accumulated damage and prolonged compensatory responses. For example, stem cell exhaustion. If we take that, the tissue lose some of their capacity to repair and regenerate. That is stem cell exhaustion. Second thing is altered intercellular communication. Cells no longer communicate or coordinate their activities effectively one to another. And then chronic inflammation. So I'm sure everybody would have come across this word inflammation in one way or the other these days. So persistent low-grade inflammation, often we call it as inflammaging, gradually affects all of the organs, and that leads to a lot of autoimmune diseases. And then dysbiosis. Dysbiosis is a very important piece that is upcoming and very fascinating field in medical science. It's the balance and function of the microbiome. So microbiome, as we all know, we are more bacteria than human. So the function and the balance of the microbiome has to be there. When the good and bad goes in imbalance, we call it as dysbiosis. And that actually, if there is dysbiosis, if there is imbalance, it influences your metabolism, your immunity, and the way your body responds to inflammation. Okay. So at this stage, what happens is, when all of this, any of this pathway is existing, the cellular change will become clinically prominent as, the reflection of these changes, how it will show in your body is by reduced strength, slow recovery. You can say insulin resistance, you can see cognitive decline, you can see frailty, and also greater susceptibility to diseases. Say, for example, if you're standing in a elevator with 12 people and a couple of them are sick and you're not wearing any mask, and the possibility of you getting sick is becoming much higher compared to when you are in younger age. That means your body's susceptibility to disease is much higher when any of these hallmarks of aging is existing. So this tells us, like, though it sounds too medical here, but it tells us that aging is a network. It is not a single pathway. So these hallmarks, they all interact and reinforce one another. So what happens is, end of the day, what happens is dysregulation of the system, and this can lead to a lot of impaired repair, mitochondrial dysfunction, leading to inflammation, senescence, and further tissue damage. Okay, that leads to the true real disease. So again, I want to say that, these hallmarks are only like a scientific framework to understand the real biology of aging. They are not like a checklist. Okay, so no patient comes to us and says, oh, I have this mitochondrial dysfunction, right? They will present in a very different phenotype, right? Through their metabolic health. They might present with their cardiovascular health. They might present with, strength and muscle function impairment. Cognition being impaired, sleep and recovery is affected. So those are the different ways they appear physiologically when any of the systems go haywire. So the hallmarks are the mechanisms, and reserve is the clinical expression. As I just said that, our patients present with multiple symptoms, increasing the vulnerability of the diseases. So all of these are the clinical expression of the declining system integrity. So at the clinical level, we see this in different stages. One is cellular integrity. How does it present? It is nothing simply put. It is the body's basic building blocks. Are they staying healthy? That is what we are focusing in cellular integrity. How well our cells and our DNA, how well our cells protect their DNA, and how well they protect their proteins and the internal structures from any damage. Then metabolic flexibility, it's another important piece. To understand that the ability to switch efficiently between the carbohydrates and the fats for energy, depending on whether we are eating, we are fasting, resting, or exercising. And simply put, like, can the body adapt its fuel use to the changing needs? So how flexible your metabolism can be. That is also a clinical expression. And then immune regulation, what does it mean? So can the immune system respond without remaining unnecessarily inflamed? Can your system act only when it is needed, and then can it switch off? And then the repair capacity, the ability to remove all the damaged components from your system to clean it up, and how well they can maintain that repair process is the repair capacity. And lastly, the system coordination. How effectively all your systems, our body is a network. It's not a single system functioning in silos, it's a network. So how effectively your nervous system, your hormonal system, your metabolism, your cardiovascular system, they communicate and work together. So are the body's different systems are working in unison, right? That's what is system coordination. So we must connect all these biological systems with the validated clinical outcomes. So the reason we are discussing all of this is to understand the process of aging in depth. And when you see a patient, you look at what is that exact parameter that I'm looking at and how do I address that with my proper intervention plan. So we should not pretend that this routine clinical testing can directly measure or reverse any of these hallmarks. Hallmarks helps us understand the mechanism, but function and outcomes guide the clinical decision. That's how I see this. So this brings to us a very important and very well-spoken topic of biological age, which is very misunderstood also when it comes to the concept of longevity medicine. So let's take a quick look into that. So chronological age, biological age, and the pace of aging. These are the different things that I want to discuss here. So what is chronological age? It is your calendar age. It's your passport age. It is stable, it is universal, and it is non-modifiable, as we all know. And biological age is nothing but it estimates how every individual's current physiology is actually reflected to the population norms. And there are different models that have been predicted to understand the biological age, and they are still in the process of study. And we all have to take it with a pinch of salt and which clock we are using, what model we are using when we are testing the biological clocks, and what is the reference population we are talking about. So these are very important parameters. There are so many tests that I'm seeing available in the market that says we can predict your heart age, we can predict your lung age. But when it comes to that prediction, we have to really look into the exact model that they are referring to, and what is that model dependent, and also what is the population they are studying this model on, right? So that's very, very important. So biological age result is not someone's true age. It is actually a model derived estimate. That's what I would say. So different models may produce different ages because every model is trained to predict different outcomes. So I prefer, when we describe this biological age, I prefer describing it as a risk equivalent age or a aging signal rather than putting a number to every organ. Okay. So always when biological age is reported, we have to understand the model that we are using, the reference population that we are looking at, and the uncertainty with the measurement. We have to understand that, as well as the clinical meaning. Why are we even testing that biological age? What is the clinical outcome that we are going to achieve with that biological age score? So this is why we should speak of aging clocks in plural, not as a single aging clock. And also the pace of aging. There are certain aging tests that can understand the rate of change, how fast you are aging. We can analyze that also. I'll get into more practical things after a few of the technical answers with the latest advancement in the aging clocks. So aging clocks can answer different questions. I'll just give a very quick summary of what are the different clocks that are currently available so people can understand how to correlate that. So one of the easiest one is a clinical chemistry clock such as PhenoAge. Okay, so the PhenoAge uses routine lab variables to estimate mortality-related physiological risk. And DNA methylation clock, it analyzes your epigenetic patterns. And it's an early clock that predicted the chronological age, but then they have advanced the DNA methylation clock now with the GRIM age, and it is trained against the mortality related outcomes. That's what they're using. And then the Dunedin pace is actually estimating the pace of aging. How fast are you aging? Are you aging every year 1, or are you aging 1.5, or are you aging 2? That can be measured with Dunedin pace clock. And then there are proteomic clocks. Actually, it analyzes all the circulating proteins in your blood, estimating the organ-specific aging. Other one is the imaging and function. So you can actually estimate your brain age, your blood vessel age, and your fitness age through certain imaging or your functional testing. So these instruments are not interchangeable. They are very specific at each purpose, and we have to understand how to use each one of them. A clock can actually predict chronological age accurately, but still have limited clinical utility. We have to understand that because they're still in studies are in process. So before adopting a clock, always ask, what is it trained to predict, and who is it validated in? Does it really change? Does a change in the score actually predict the health outcome of the patient? These are very important questions we have to ask before using any of these age clock, and they're also very expensive to even administer these aging clocks. So one clock that is particularly very relevant and very easy to administer for, and it is good to democratize, is the PhenoAge. So PhenoAge is very easy to put into practice, and it can be applied with the routine lab tests that we are using. PhenoAge has 9 routine available biomarkers plus the chronological age. This comprises of the PhenoAge, and there is a calculation, if you can look into Google, there is a calculation formula for calculating your PhenoAge based on these parameters. So you can look into that. So it includes variable domains. If you can see albumin, which really talks about your liver, it talks about your nutritional status, it talks about your inflammatory status. And then if you look at creatinine, it tells you about your kidney function, your muscle-related physiology. And then glucose talks about your metabolic regulation. HSCRP is one of the markers of inflammatory burden in your blood. And lymphocyte percentage, and WBC tells about your immunity status. And when you look about MCV, RDW, these are hematological and nutritional signals that we can pick up. And alkaline phosphatase is the hepatic and skeletal physiology. So you're literally covering so many organs in this parameters, and put together you get a score, and that is called the PhenoAge score. The biggest advantage of this particular PhenoAge score is its accessibility. No expensive omics are needed. No expensive platforms are required to even administer this. But it remains super sensitive to acute illness, assay units, and transient changes. So we have to be very sensitive about the fact, and we should know when to apply this PhenoAge and when not to apply this. So a fall, if you see a fall in PhenoAge caused by resolving an infection or any inflammation, is not actually necessarily meaning that they have reversed their aging. So put that into a clinical context, and we have to calculate this PhenoAge. The next step is to actually recognize that aging may also be asynchronous across organs. It's very important to know that. And so one person can have several aging trajectories. So what I mean, this is an illustrative graph. So if you look at it, it has like an organ-specific proteomic research done, and it shows like organs can age at very different rates within the same individual, and that's important to notice. There was a study done in 2023, and Nature had published the study. It assessed that proteins associated with 11 organs across more than 5,000 individuals. Approximately, they showed like 20% demonstrated accelerated aging in one organ, and then about 1.7% in multiple organs. So accelerated organ aging, meaning like one of the organ can age faster, were associated with corresponding diseases and the mortality. So we have to understand that aging can differ between each and every organ. And again, there are different tests for this. Again, it remains as an emerging technologies. So they should not be presented as a definitive diagnosis. We cannot just say that your brain is aging faster than your heart, and we have to take a careful step when we are announcing it that way. And until these platforms actually mature, all these testing platforms actually mature, we can still assess the organ level aging using all the validated clinical risk and function, which is what I'm going to talk about in the next few slides. So I personally, as a clinician, I use all of these parameters. So vascular age can easily be calculated with your blood pressure, ApoB, the patient's smoking status, and then a coronary artery calcium score when indicated, and then ABPI to understand your peripheral artery stiffness, pulse wave velocity. These can actually give your vascular age. And then the lung age, you can use your spirometry and the patient's existing symptoms and their exposure to environmental toxins and smoking. All of this can be taken into account. And kidney age should not replace the EGFR. And you look at their albuminuria and the CKD status, and then you go by their kidney age. Again, it's an estimate. There is no exact kidney age calculation. Muscle age, again, it should reflect the strength of the muscle, the power, the gait, the balance, and their body composition using a BIA or a BCA. That's your muscle age. And then the brain age should include the cognitive status. You can do cognitive stress index score or insomnia score. So there are different models of testing cognition, MoCA, the MoCA questionnaires. So we can use all of that to understand the cognitive factor. And then you understand the vascular risk as well as very importantly, hearing and vision. It really relates with the brain age. So every patient has to go through hearing and vision screening, and of course their stress and mood. So an organ age number is only valuable if it clarifies risk and leads to an appropriate action. Without that, I would not specify any of this. If you are able to make a difference in your intervention plan based on these factors, absolutely you should test all of this. So, and again, we must avoid converting every physiological measurement into an age simply because patient finds age easier to understand. So, in fact, the most useful measure of healthy aging may be age, maybe not be the age at all, not giving the score at all. So, rather, I would put all that effort in telling them how well they are aging by understanding the reserve. And that is much more validated than a single score. So the most useful longevity metric is not the age, it is the reserve. So reserve describes the capacity to tolerate the stress levels and still maintain or regain all that function, right? So how do you measure the cardiorespiratory reserve? We can do the VO2 max test. It's a very easy, just like a treadmill test, we use the VO2 max test. And then we can look at the heart rate recovery in HRV, and then 6-minute walk test we can do. And then for the musculoskeletal, we can, for the reserve of the musculoskeletal system, we can assess the strength, we can assess the power, how well they can balance. And for the metabolic reserve, we can use, waist hip ratio, the liver fat, and then the glucose control. Cognitive reserve, as I said earlier, it provides resilience against a lot of neuropathological diseases. So how do we preserve that executive function? How do we preserve that sensory input? And that's what we need to measure. And then the psychological reserve is how well you can adapt to the existing situation, and how well you can participate, and how well you can connect with the society. So these are all the different reserves we can actually measure instead of giving one particular age. And not only the measurement, and this is what we need to focus on improving when it comes to improving the physiological reserve. Patient actually care probably less about when they are told, they are biologically 5 years younger. Maybe it can be a boost, but they care more about when they see themselves climbing, flight of stairs independently, and they can travel solo, and they can remember and recall names of their family and friends. And if they can recover faster from any diseases, and if they can remain independent, that's what really matters to patients. So the good news is that measuring this does not require a luxury longevity clinic. As we all know, like across the globe, longevity clinics are becoming more like a luxury centers. So to measure all of this, I don't think we need a luxury longevity clinic. All we need is the right parameters to look into. So if I can say, how can we have a minimum viable longevity assessment that can fit into any clinical office or any hospital is, it's already, I think it's existing in majority of the places, but how do you put that together? For every patient, we should begin with routine medicine that already offers, which is like your medical history, your medication history. And as we know, like proper history gives out the diagnosis already 50%. So, and then we look at the basic parameters like blood pressure, WHR, which is waist hip ratio. And then we ask about the use of substances, recreational drugs. We ask about activity, the sleep, and their mood. And then what about their social life? These are all the things that we take it from the history part. And then when it comes to appropriate function, we ask about the grip strength or the chair rise testing. How can they independently move? And how is the grip strength using the dynamometer? How can we measure the grip strength? This we can look at, and the gait and the balance we can look at. And then the VO2 max with the cardiorespiratory fitness, and as well as cognitive and sensory screening. And the targeted risk, I would say, using the targeted laboratory testing like A1C, fasting insulin, HOMO-IR, your lipids with ApoB and LPA when needed. Those are like targeted risk testing. And of course, the liver and renal markers and disease-specific testing we can add. And apart from that, the advanced testing modalities like the pulse wave velocity, putting a CGM, a continuous glucose monitoring on the patient. Can we do a DEXA scan to understand the bone density and the fat mass? And can we do a sleep study if the patient is having resistant weight gain? And if they have like sleep apnea, can we do a sleep study? Those are all an omics, all the multi-omics that we can do. Those are all the advanced way of testing. So once we identify the declining reserve, the most powerful intervention is often surprisingly very familiar. I'm not sure if how many of you are going to guess what is the most powerful intervention, and that is one of my favorite intervention is movement. Movement is the closest thing we have a multi-system gerotherapeutic, So what we do is, I even call movement is medicine. So exercise actually affects multiple hallmarks. We discussed 12 hallmarks in the beginning of the lecture. So exercise affects multiple hallmarks that we discussed and multiple organ systems simultaneously, and nothing can touch like that. So it improves your insulin sensitivity, it improves your mitochondrial capacity, the endothelial function, which is your blood vessel function, and then your muscle, your bone, and your cognition, your sleep, your mood, and the way your body asks for things. Sometimes you can listen to patients saying, I just cannot stop craving for sweets. When they start moving and exercising, their bodily asks are completely different. So this is one magic that we need to really inculcate in every patient that we encounter. In one of the studies, adults achieving 7,000 steps daily had approximately 50 to 70% lower mortality risk than below 7,000. I know this number was 10,000 earlier, but now it came to 7,000. But this is one of the latest studies I came across. So this is an association. It's not like a guarantee. It's not like I do 7,000 steps, but I still eat all of these things that are, that are not healthy, and I still do all of the substance uses. So it doesn't work like that. It is a cohesive arrangement. So 7,000 steps plus what else you do, right? So this is an association, not a guarantee, and it's a dose-dependent response relationship that we need to understand. And also, meta-analysis, one of the meta-analysis was suggesting like muscle strengthening activity is associated with approximately 10 to 17% of lower mortality. So muscle strength is something we need to really emphasize with our patients, not just the regular walking, and the pace of walking is important. The weighted walking we can encourage, and then moving them to strength training and resistance training. These are all the steps of exercise prescription. And cardiovascular fitness remains one of the strongest functional predictors of the long-term outcomes. It's one of the sensitive longevity markers. One is the VO2 max, another one is the grip strength. So absolutely, we should include this in our testing. So I would not say exercise reverses aging, but I would definitely say exercise builds that reserve and reduces that vulnerability across multiple systems. So it is a very important statement that we need to understand, and also reflect that on our patient encounters. So, but telling patients exercise more is not a medical prescription. There is a proper format, like how we do prescription with our pharmacies. The same way exercise has to be prescribed in a proper fashion. I look at it as 4 different phases. One is aerobic activity. See, exercise prescription really requires like the modality, the dose, the intensity, and frequency, and how do you progress in each of the exercise you're doing. So these are all the things that we need to include when you prescribe an exercise. So aerobic activity actually builds your cardiorespiratory and metabolic capacity. When you look at resistance training, actually it preserves the muscle mass, which is actually the key as you age. So muscle mass, your strength, your bone health, and the glucose disposal, which is all dependent on your muscle mass, and that comes from resistance training. And then the power and balance. So power training matters because power declines earlier and faster than the strength. So we need to focus on the power and balance as well. And balance training reduces the falls, which is one of the biggest risk factor in older adults. So balance training reduces the falls and maintains that confidence and participation. So when they feel balanced, they start exercising more. So these the factors: aerobic base, strength, power, and balance. And then the last one, it's one of the key piece of the prescription that we never fail to add, is the recovery. You can run, you can walk, you can do all of this gym activities, but if you don't give enough space for recovery in your body, that actually backfires, even though you have done a lot of good things by exercising. So recovery is a key piece of exercise prescription. So we can encourage sleep, we can advise them adequate protein, adequate creatinine, and rest days. How do you balance your rest days, and how do you progress appropriately? So these things have to be discussed very clearly in the prescription of any exercise. So, and also we need to measure the responses, not just give the exercise, make them do. Bring them back and you measure those responses with the strength, with the gait, with the grip strength, with the blood pressure, and also the VO2 max. We can actually measure the responses with all of these parameters. See, you always start with where the patient is at this current baseline, and then you build on top of that. Movement cannot be separated from nutrition. We have to understand that, because the tissue adaptation when you're exercising, it actually requires a good amount of substrates, and that comes from the nutrition. So that is my next slide. We're going to talk about nutrition that works through patterns, adequacy, and metabolic context. And this is a very simple way that I look at nutrition. So we need to start with a dietary pattern rather than an isolated nutrient. Take a lot of proteins, take a lot of fats, go keto. So these are all isolated nutrient way of addressing things, but rather I would go first with the pattern, minimally processed, majority plant forward, and culturally familiar. Asking a client or a patient who has never taken Mediterranean diet and asking them to switch to Mediterranean diet is not going to happen. It's not sustainable. So trying to be culturally familiar is very important. Next is the adequacy assessment. How do you assess the protein, how much fiber, and how do you add micronutrients and total energy to match the patient's needs? That's important. And then you look at the metabolic fit. How does it actually, according to their glycemia, or according to sugar levels, or according to their liver fat, you actually tweak the medications, exercise prescription according to that. And then lastly, the adherence. Adherence is more of, you have to answer to their taste palette. That's very important. And it has to be accessible and affordable. And then we have to work with, it has to work with the family context. And how do you make it accessible during their busy work life? How do you make the diet easily accessible? So these are all the important factors when it comes to adherence. So pattern, adequacy, metabolic fit, and adherence are very important. And in the diabetes prevention program, there was in one of the diabetes prevention program, they noticed that intensive lifestyle intervention alone reduced the diabetes incidence by 58%, whereas the metformin only did 31%. Okay, so it's a very impressive fact that we need to understand lifestyle alone can change a lot of things in your body and can create a magic. So next, when it comes to exercise and nutrition, the next thing that comes to mind is the supplements. If someone is not eating right, can we just supplement the protein? Can we just supplement the vitamins? So nutrition and exercise, they deliver their benefits fully when recovery physiology is protected. When talking about supplements, they should correct a deficiency but should not replace the existing diet. Okay, so let's talk about the recovery physiology next. So when I talk about recovery, I don't talk about the wind down time, or I don't talk about going for movies. I don't talk about even infrared sauna or other optimization therapies out there. But my first go-to is sleep. Sleep is not downtime. Actually, it is the one of the active maintenance work that happens in your body. It's a period of metabolic, immunological, and neurological and hormonal regulation. All of this happens when we sleep. So we need to assess more than the duration. We need to assess other things when you talk about sleep to your patients. So usually we say 7 to 9 hours in adults, but more than that, can we talk about the regularity? Can we talk about the quality of sleep? And then the circadian timing, that's also very important. So most adults need 7 to 9 hours, but individual context also matters. One of the large observational data suggests that the sleep regularity matters more than the duration. It's very interesting fact. How regular are your sleep times? Are you going to the bed at the same time and are you waking up at the same time? Matters more than whether you're sleeping 7 hours or 8 hours. So that regularity, consistent sleep time is very important. And then the quality, like, are you having screen insomnia? Are you having apnea? Are you having restless leg syndrome? Are you in pain? So those things have to be addressed with our patients. And then lastly, the circadian alignment. So eating your meals 3 hours before bedtime, and keeping it light, and keeping the activities light before the bedtime, not going to the gym just before you hit the bed. So those things, the circadian alignment matters a lot. Treating sleep disorders is definitely not a wellness fad. We need to look into that because it truly reflects on all of the bigger diseases that we think about: cardiovascular, your metabolic disease, your cognition, mental. It's a mental health medicine, actually. So digging into all of these parameters when you talk about sleep is very crucial information. Sleep also brings us to another neglected element, that is the body's capacity to shift from demand to recovery. And what is that all about? So the nervous system regulation, how does that happen? So the nervous system must repeatedly adapt to your work, to your illness, or your responsibilities, or if there is any trauma and any uncertain situations like war or flood or whatever that is, you have to adapt to that. Your body has to adapt to that. Nervous system has to adapt to that. So normally adaptation is healthy, but when the constant adaptation happens, that causes this allostatic load, which is like excessive wear and tear in both physical and mental health, is the allostatic load. And that leads to a lot of physiological disease conditions. So clinical signals can induce changes in blood pressure, it can change your sleep, it can change your glucose metabolism, and even your health behaviors. When your nervous system is not rested enough, normally the activity that gave you motivation cannot be the motivating factor anymore. So regulation of your nervous system and looking at your constant wear and tear is a paramount important thing. So interventions, how can you really regulate your nervous system? Really getting into the breathing pattern, slow breathing, every day doing some kind of breathing exercises that calms your nervous system, that stimulates your parasympathetic nervous system. And then even getting into cognitive behavior therapy or mindfulness based approaches can also help you to calm down your nervous system. And yoga, slow stretches before bed can also calm down. And then exercises on every day in the as a routine. And sleep restoration, if you are lost your sleep because of some activities, catching up on that. And then making really good social connections and having a purpose in life. These are the ways we can actually tone down your fired up nervous system. And again, HRV is highly context sensitive. We need to look at the trends rather than individual isolated readings. And again, recovery is not only an internal biological process, it is also shaped by your relationships and the environment that you're living in. So absolutely focus on down regulation of your nervous system to calm down your nervous system every single day. Give prescriptions for these as well to your patients. So relationships and sensory health are the biological inputs. So what do I mean by that? The social connections should be treated as a health determinant, and they're not like a soft lifestyle extra. So one of the meta-analysis that was done on of 148 studies, and more than 300,000 participants were there in this study, and they found 50% greater likelihood of survival among those with stronger and social relationships. So building that connection, building that social pool, that's very important, and it should be part of your questionnaire with the patients. So always ask about the loneliness and isolation, ask about if they have any caregiving burden, and what is the meaningful role they are playing in their life, and how do they participate in the family and community works where they live, and is there any sign of depression. Always do the PHQ-2 and GAD scores. And if they have lost their purpose, try to bring them back with nurture that purpose and participation that they can have. And as I earlier said, we definitely have to screen for hearing and vision, which are also the crucial inputs of the cognitive and social reserve. When they lose the hearing and vision, they kind of seclude themselves from all of these social activities. So healthy aging for me is therefore very partly medical and partly behavioral and partly societal. We have to understand that. So this broader understanding also creates a space for thoughtful integration. What I mean by integration is, so when I say integration, it's all about modern diagnostics should define your diseases. It should define the risk, it should define the urgency and the safety. And then when you talk about lifestyle medicine, it forms the most evidence-based therapeutic foundation, and that should be part of every intervention plan. And my background also has, like, I did my Siddha medicine, which is one of the Ayush systems of medicine. That is my first medical degree. And then I went into conventional medical school of doing MBBS and MD from US. So having done both systems, I also look into the Eastern side of things that can contribute culturally and that can resonate around the nutrition, around the exercises, around the movement and breath and sleep. I use those techniques as well. So the integration does not mean indiscriminately adding a lot of therapies. So we must actually avoid replacing the proven treatment, whatever that may be. And always when you're prescribing a herb, check the herb drug interaction. It's a must. And then evaluate whatever supplement we're using to replace the deficiencies, that the product quality and contamination have to be evaluated. Look for heavy metals. What is that source of the product? That has to be evaluated, and define the measurable outcome. Why are you doing and what are you doing? So that question has to be answered and define that measurable outcome, and stop the intervention that are ineffective and harmful. So most of the times I look at how to deprescribe than to prescribe. So that's when do you need to stop all these supplements. That knowledge also has to be there. So the common endpoint is being safe for care, having a safer care, having a better function, and making them to participate in a sustainable way. That's how that integration has to happen. And I just wanted to share what are the things that we can readily use in a clinic, and what is promising and selective and what is still experimental. So as we discussed so far, all the risk factor control, like, already in practice, or the exercise prescription, the nutrition, the sleep assessment, all the substance use cessation, vaccination, functional assessment, psychosocial care, all of this can be readily used. But some of them are promising but still selective, or the biological age clocks that we initially discussed. The continuous glucose monitor in selected non-diabetic use. It is useful in non-diabetes also, but in selected population. And advanced imaging can also be promising and selective. And again, organ age testing, as I said, we have to be very selective in why we are using what we are using. And still experimental for healthy aging, or certain drugs that are still under research, like rapamycin. And metformin, rapamycin, or other senolytics that are existing in the market are important research areas. But routine off-label longevity use still remains experimental. NAD infusions, or even peptides that are spoken very widely, plasma exchanges, cellular reprogramming, all of these are still under experimental stage. So supplements are another area where mechanistic science is frequently overinterpreted. So what I mean by that is, when you want to give a supplement, the longevity, when you talk about longevity, people often see it as all about supplement stacking. So it doesn't have to be that way. So before prescribing any supplement, you always ask 4 questions. Is there a documented deficiency or a clinical indication for that supplement? Because you would have tested that in your biomarkers. And second question is there an evidence for a meaningful human endpoint? That is the second question. And then third is the dose, the sourcing or the purity of the supplement, or the interaction profile has been checked? That is the third one. And the last one is, can we measure benefit and stop if it is not effective? So that's another question. So always ask these 4 questions before you prescribe any kind of supplement in the space of healthy aging. So the pathway is not a prescription, we have to understand. If we remove the commercial complexity in the space of longevity medicine, it becomes a surprisingly practical solution for a lot of the clinics. So every doctor can practice longevity medicine in 5 moves. So what do I mean by that? First thing is, find the silent risk, look at their parameters, look at their, even before they become symptomatic with the disease, look at that parameters. Second, measure an element of reserve. It's very important. Apart from the reason they came, you always measure a point of reserve, not only disease markers, right? So you measure the reserve point. Is that the strength you want to pick on? Is it the gait or balance? Is that the VO2 max? Is it the cognition? So measure at least one reserve during their encounter. Third one is prioritize. Okay, so prioritize the largest modifiable risk that you have measured and not the exotic marker that came up in the labs. And fourth is prescribe a specific and progressive intervention. Okay, so you prescribe, you analyze, and then see if they're progressing in the right direction. And fifth is remeasure the function, remeasure if they're adhering to your principles and protocols, and the risk and the patient's own goals. You can think they need to get into lifting off 15 kilos, but what is their goal? We need to have a open conversation about that before you do that prescription. So understand, going in the stepwise fashion with all these 5 moves, every doctor can become a longevity focused provider. So I just wanted to add, like, the time becomes a problem with many physicians when they want to sit with the longevity layer on the top of their consultation. So I put a very rough trajectory here. So we can start with, the question of what has changed in the last year. And you can ask the question of what matters to you at 70s and 80s. And future-oriented questions, what do you want to remain able to do when you're in your 70s, 80s? Those questions really matter to understand where their trajectory is. And review all the major risks that we just spoke about. And then reserve, as I said, can you quickly do a grip strength test? Can you do a chair rise test? And can you ask them to, recognize any activity level? And what is their sensory, cognitive or sensory clue that you can pick up? So again, choose one risk from this list and one target, and then work on that. Write the intervention as a dose and agree on what will be measured at every follow-up. And small additions, for me, small additions repeated longitudinally can be more valuable than one-time premier longevity package in 1 year. Okay, so every visit we can actually add all of these longevity parameters. Rather than, in the beginning of the year, I spent 50,000 rupees to do a full body checkup. Doesn't have to be that way. So small additions repeated longitudinally outperform a one-time longevity package. So again, democratization, when I talk about democratization, it is not about making all of these expensive tests cheaper, but it is making useful care scalable. How can you scale your care? So community level longevity clinics, we can do that. We can actually bring in movement clubs, assessing the strength and controlling the substance uses. A big factor is the environment they live in, understanding what environment they live in, what is their exposomes, like what is that they are drinking from. Is it plastic bottle? Is it a stainless steel bottle or a glass bottle? And are they eating more outside or home cooked foods? And what is their home environment like? Are there any industries or any other sewages that are next to their home? So these kind of environmental exposures have to be assessed. And then the social connections, are they being engaging in their social life? And do they have a good family and friend circle? So those things have to be understood. And then when it comes to primary care screening, we can do the risk assessment, the functional assessment, and the guideline-based treatment. And coaching and follow-up can be done. And advanced care can include all of the other tests that we previously spoke. See, the technology should reduce the friction and extend the access, and it should not create anxiety or widen that inequity. So we can still practice longevity in a much scalable way without having to do expensive tests. So for me, the future is a longitudinal health record of reserve. Reserve is the key word that I want to focus in this entire presentation. How can, as a physician, we preserve the reserve of the patients? So in our clinic, we have 3 models: biology, behavior, and being. In the biology, we assess all the diagnostic markers. In behavior, we look at their movement, we look at their nutrition, we look at their sleep pattern and their substance use. And in the being, we talk about the breathing pattern, the mood, the stress, and the purpose of their life. And of course, function, we have a functional gym that actually assesses all of these factors that we just spoke about. Here is a very simple case scenario that I wanted to explain. So it's a 52-year-old male with no diagnosed disease and a normal BMI. And all the annual tests are described as normal in his blood test reports. But he has poor sleep, he has high stress, and he explains no training, strength training, or any exercise training. He has very lower level of fitness, and his waist size is enlarging every year, right? So a disease-focused assessment, if you look at the lab markers and you say it's all normal, that may reassure him. But when you look at the longevity lens, if you add the longevity lens and look at this assessment, it detects the trajectory for a lot of the diseases. He has rising metabolic risk, he has low cardiorespiratory reserve, he has low musculoskeletal reserve, and he has very inadequate recovery because of his high stress and poor sleep. So the action is not expensive clock or supplement stacking here. If you look at it, it's progressive exercise, sleep assessment, a sustainable dietary pattern, stress support, and appropriate risk factor modification. That's all we need. So it brings back to me the central correction here. What do we need to do as a physician when we see a patient is changing our outlook when we take a history, asking the right questions to understand the trajectory rather than just focusing on that one particular problem the patient came with. So this is the correction when we started with the conversation of aging. What is the lie about aging? So I want to say the correction to the aging lie here. So the aging is real, but we need to know its trajectory is heterogeneous. The biology matters, but reserve is what patients live with. So the reserve is what patients experience in everyday life. And measurement is useful only when it changes a decision or only when it impacts the patient's life. And intervention works when evidence, safety, and adherence and the context aligns very well. And lastly, longevity medicine belongs in every specialty because every specialty influences the future function. It is not meant for one single specialty. Everybody can practice longevity. Our role is not to promise more years. Our role is here to help patients arrive in those years with a greater physical capacity, with a greater cognitive clarity and emotional capacity. So the lie was never that aging happens. The lie was that the decline is fixed. The lie was that the decline is uniform. And the lie was that the pattern of aging and the diseases that come with it is beyond the reach for everyday medicine. So we may not control, the passage of time, but we can definitely influence how much reserve our patients carry into it. With that note, I quickly want to share, this is the clinic that I'm working at in Coimbatore. I'm the co-founder of this clinic and the chief clinical strategy officer. 3-5 Revive was born 4 months ago in the city of Coimbatore. And people ask me why 3 and why 5. So it's one number, but two worlds. 3 is like just one number, but two worlds. The name in 3 in the name is not definitely decorative. It is a deliberate pairing of two lenses on the same patient. So the Western pillars, we check biology, behavior, and being, and the Eastern pillars, with my training in Siddha medicine, we use the Vata, Pitta, and Kapha, which are the Eastern constitutional patterns, and it explains why the same stressor produces different results in two different people. So the neither of the system replace the other. They are read together at 3-5 Revive. And then the same thing with 5, one number, two worlds. So the pathways are actually the operating model. We have Prakriti Precision. We focus on prevention, ultra personalization. We make the patients participate and we show the progression. And the elements, the Panchaputas like water, earth, fire, air, and space, the biological targets those pathways act on. So they are mapped into hydration and circulation. They are mapped into structure, metabolism, and respiration. They're mapped into recovery, regulation, respectively, when you look at water, earth, fire, air, and space. So this is our philosophy of practice. And our job at 3-5 Revive is to help patients arrive in their later years with maximum capacity, to help them age on their terms. So that brings to the conclusion of my presentation. So thank you all for patiently listening and giving me an opportunity to share what I know about the lies of aging and what is happening in the field of longevity medicine. Happy to take any questions. Thank you once again.
Thank you, ma'am. Thank you so much for your wonderful presentation. It was very informative. I think
Thank
there's one question which I have got for you. Why do foreigners tend to age much gracefully than Indians in general?
Can you repeat the question? Are you sounding a little far from me?
Why do foreigners tend to age much gracefully than Indians in general?
Excellent question. So that's a great observation, first of all, Dr. Arun. They age gracefully because I mean, having practiced in US and UAE and a little bit in Ireland, I understand the process of aging is much streamlined right from their mid-age. They understand the purpose of living much earlier in terms of they don't run behind life. They focus on living life as well. So that's one thing. And also the awareness of all of this healthy living is much more present in the Western world than in our Indian subcontinent. And that awareness is lacking, and they age gracefully because there is a system for testing all of these things that we just discussed. There's a system in place, and that is lacking here. There's a lot of easy fixes here in terms of when it comes to preventive care or when it comes to longitudinal care. We are very rushed here. We don't focus at the end point, rather we want to put a band-aid on the existing problem. Whereas the awareness of looking at a holistic picture and the comprehensive picture is much more prevalent in the Western world. They ask right questions. They look at 10 steps ahead of what they want to know. And especially for the last few years with ChatGPT and other AI models being there, they come very well prepared to ask those advanced questions. That awareness is the main reason I think they're aging more gracefully, and the resources they have to use that in that particular space of the world, I think that's more there compared to Indian subcontinent. And also the environment, I feel like there's a lot of environmental exposure. Exposomes are really triggering a lot of diseases here in terms of your hygiene around where you live, in terms of the air that you breathe, in terms of the stress that you handle. I think it's much more pronounced in the Indian population than in the Western world.
Yeah, I think you summed up very nicely. So I don't want to take credit for the question. It was Sai Krupa Ramesh who had the question. So I think one thing I wanted to add is um, aging is a natural process, but it is not a disease. We need to understand that. And we in India, we are in the process of reactive medicine. When something happens, we react to it. When there is a fever, when there is diabetes, we treat those things. So we are still in the process of reactive medicine. So the future is preventive medicine, and with the invention of AI, we are going into predictive medicine now. So preventive medicine has already been practiced in US and UK. That is where they prevent most of the diseases, and they tend to age much gracefully than as Indians. So because we don't, first of all, we don't accept we have a disease. There are still people who are undiagnosed diabetic, undiagnosed high blood pressure patients who are almost the gist of we are looking at the tip of the iceberg here. So there's a big iceberg which is sitting inside, which we don't treat at all. So people are ignorant in those terms, especially in the rural population. We are still in the process of reactive medicine rather than preventive and predictive medicine. I think
Exactly.
that's a wonderful talk. Yeah, good.
Just to add on to that, Dr. Arun, I also would say that awareness of, why should I even go to a doctor when I'm doing well, right? That's the
Exactly.
question that is existing still.
Exactly.
That concept of going to a doctor when you're not sick is not there here. You should still go
Exactly.
see a doctor yearly once to make sure after 40s there are certain things that actually go down in your system automatically. So that needs to be checked out, and I would definitely say nobody is going to be 100% healthy at all times. So it is okay for
Exactly.
any individual to go to a physician on a regular basis, on a yearly basis, to get those things checked out. That concept of going to a doctor when you're not sick is another factor that I would say
Yes.
that we are not aging gracefully. It becomes too late to fix, when they come too late in the process of the disease, then there is no choice other than putting on polypharmacy, right? So that's the biggest, lack of awareness I'm seeing here.
I think we have one more question in the chat box from
Sure.
Sai Kripa Ramesh. What do you think is the ideal age from which one should start looking after their biological age?
Excellent question. I would say, I wouldn't say look after your biological age, but after 30s, your body will take care of you until you're 20. Then after that, I think you have to take care of your body after 20, because the systems slowly start, in the decline phase, right? And again, it depends on how well you take care of yourself, and the decline happens depending on your care model. So I would say after 30s, you should start looking into all of those parameters and making sure you're having a good VO2 capacity, making sure you're having a good grip strength, and making sure you're functionally fit. Those things have to happen at least starting at 30.
Yeah. Thank you so much, madam. Thank you so much for your wonderful presentation. If there was no more questions, we'll end the webinar. Thank you, madam. Thank you so much for your wonderful presentation.
Thank you, Dr. Arun. Thank you for
Bye.
having me. Yeah. Bye-bye.